Welcome to this video on ECG interpretation in the emergency department, focusing on mastering high-risk patterns. This guide is designed for emergency medicine physicians. Before interpreting an ECG, ensure technical accuracy. Check that paper speed is 25 millimeters per second, voltage calibration displays two big squares, and that lead AVR is negative. This video covers essential criteria for ST elevation, depression, and T-wave changes, essential for identifying myocardial ischemia. Be aware of high-risk end-STEMI patterns, such as diffuse ST segment depression with marked ST elevation in lead AVR. This often indicates severe left main or multivessel disease. Patients may present with refractory chest pain or cardiogenic shock, requiring emergent intervention. The South African flag sign indicates acute occlusion of the first diagonal branch of the LAD. Look for localized ST elevation in leads 1, AVL, and occasionally V2, while other anterior leads remain normal. Don't let reciprocal changes in lead 3 mask this high-risk lateral wall injury. Posterior myocardial infarction is another crucial pattern. Signs include ST depression, broad R waves, and a dominant R wave in V2. To confirm, use posterior leads V7 to V9. Diagnostic criteria require at least 1 millimeter of ST elevation in men under 40, or 0.5 millimeters for others. Right ventricular infarction often accompanies inferior STEMI. Watch for greater ST elevation in lead 3 than in lead 2, along with elevation in V1. Use right-sided leads, like V4R, for confirmation, where 0.5 to 1 millimeter of elevation is diagnostic, depending on age. De Winter's T waves are an anterior STEMI equivalent, indicating proximal LAD occlusion. Key findings include upsloping ST depression in precordial leads and prominent peaked T waves. Recognizing this pattern is critical, as it requires the same emergent reperfusion strategy as a standard anterior STEMI. Wellen syndrome is highly specific for critical LAD stenosis. Look for deeply inverted or biphasic T waves in leads V2 and V3 during a pain-free state. Patients are at extreme risk for an extensive anterior wall infarction and require emergent management. Regarding Brugada syndrome, always refer to standard electrophysiology guidelines for the identification of the different types. Accurate diagnosis in the emergency department is essential for managing risk effectively. For patients with LBBB or paced rhythms, use the modified Scarbosa criteria. By calculating the discordant ratio, ST elevation divided by the preceding S-wave depth, you can improve diagnostic sensitivity to over 90% compared to the original criteria.
Be careful not to mistake hypertensive crisis for hyperacute T waves related to ischemia. These T-wave changes can occur due to extreme blood pressure and are generally transient, disappearing as blood pressure is controlled. In summary, mastering high-risk ECG patterns requires strict adherence to standardized criteria. Maintain high suspicion for STEMI equivalence, utilize additional leads liberally, and apply the modified Scarbosa criteria when necessary. Your vigilance can ensure life-saving interventions for your patients.